Bud Chiari continued. Acute intraparenchymal findings include an edematous, mottled liver, nutmeg. Acute intraparenchymal findings include an edematous, mottled liver, nutmeg liver, with sparing of the caudate lobe. As discussed above, the caudate is often spared as it drains directly into the IVC. Flip-flop enhancement may be seen, with early central enhancement and delayed peripheral enhancement. Chronic findings are marked by progressive liver failure, with caudate lobe hypertrophy and atrophy of peripheral liver with prominent regenerative nodules. Veno-occlusive disease. Veno-occlusive disease, VOD, is destruction of small hepatic vessels secondary to toxin exposure, with patent hepatic veins. VOD is often seen in patients after stem cell transplant and exposure to certain chemotherapy agents. Imaging findings are nonspecific. In the acute phase, periportal edema, narrowing of the hepatic veins, hepatomegaly, heterogeneous hepatic enhancement, gallbladder wall edema and ascites have been reported. Liver Doppler may show decreased velocity or reversal of flow in the portal veins. In contrast to Bud Chiari, the caudate lobe is not spared. The findings in chronic disease are similar to those of cirrhosis. Differential diagnosis in patients after stem cell transplant includes graft versus host disease (GVHD). Veno-occlusive disease is more likely if the right hepatic vein diameter is less than 0.45 cm, while GVHD is more likely if there is associated small bowel wall thickening. Peliosis hepatis. Peliosis hepatis is a rare benign disorder of sinusoidal dilatation and formation of blood-filled lacunae. It is often idiopathic but may occur due to certain medications, including steroids, oral contraceptives, tamoxifen and methotrexate, immune disorders, including HIV, immunosuppression post-transplant, and infections, including HIV, TB, Bartonella. CT and MRI show early central enhancement with delayed centrifugal enhancement. Ultrasound may show a non-specific hyperechoic mass. Cardiac hepatopathy. Cardiac hepatopathy is passive hepatic congestion from cardiac surgery, heart failure, constrictive pericarditis, or right-sided valvular disease, which may ultimately lead to cirrhosis. Imaging findings include enlarged hepatic veins in IVC, with reflux of intravenous contrast from the right atrium into the IVC and hepatic veins. The liver is typically enlarged and demonstrates mottled enhancement, nutmeg liver. Ascites is usually present. Hepatic Doppler. Normal anatomy and Doppler waveforms. MPV. CHA. RPV. Raw LPV. The normal hepatic artery waveform is pulsatile and towards the liver, called hepatopetal flow, pedal equals toward. Normal hepatic artery waveform. Doppler tracing shows a pulsatile waveform, above the baseline, indicating hepatopetal flow. The peak height corresponds to the peak systolic velocity while the trough corresponds to end diastolic velocity. A typical resistive index, Re, is 0.55-0.7. Re is calculated by peak systolic velocity, end diastolic velocity, peak systolic velocity. The normal portal vein waveform is above the baseline, hepatopetal, and gently undulating, phasic, with velocity ranging from 16 to 40 cm/sec. The hepatic veins feed into the IVC in the right side of the heart. The spectral Doppler waveform is pulsatile and representative of changes during the cardiac cycle, though with the majority of blood flowing antegrade, away from the liver and towards the heart. The normal hepatic venous waveform has four distinct components, the A, S, V and D waves. Normal portal vein waveform. Normal hepatic vein waveform. Normal hepatic vein waveform. Anterograde. Into heart. Away from transducer. Retrograde. Towards transducer, S wave. Ventricular systole. A wave. Atrial systole, D wave. Ventricular diastole. V wave. Tricuspid valve. Opens. A wave. Atrial contraction, during which blood is forced retrograde, away from the heart, into the liver. S wave. Ventricular systole, during which a large volume of blood returns to the right atrium. V wave. Atrial overfilling, followed by tricuspid valve opening, peak of the V wave, and early ventricular diastolic filling of the right ventricle. D wave. Continued filling of the right ventricle during ventricular diastole, during which a smaller volume of blood returns to the right atrium. Portal vein pathologies. Portal venous pulsatility. While the normal portal venous waveform may be gently undulating, described as phasic, a pulsatile portal venous waveform is abnormal. The differential diagnosis for a pulsatile portal venous waveform includes tricuspid regurgitation and right-sided heart failure. Portal vein thrombosis. Thrombosis of the portal vein can be bland, simple thrombosis, or may be due to tumor invasion. Bland portal vein thrombus can be caused by a hypercoagulable state or may be due to local inflammation from pancreatitis or hepatitis. In infants, omphalitis or dehydration may also lead to portal vein thrombosis. Tumor thrombus is most commonly caused by HCC and is referred to as tumor in vein. Grayscale transverse image of the porta hepatis shows echogenic debris within the main portal vein, arrows. Color Doppler confirms partial portal vein thrombosis with lack of flow in the proximal portal vein, arrow. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Portal vein thrombosis, continued. Ultrasound of portal vein thrombosis shows lack of portal venous flow, often with echogenic thrombus within the portal vein. Expansion, enlargement of the portal vein can be seen with either bland or tumor thrombus. On color Doppler, flow within the thrombus suggests tumor thrombus. One potential pitfall to be aware of is slow, less than 16 cm, sec, or stagnant portal venous flow in the presence of portal hypertension, which may mimic portal vein thrombosis. Long-standing portal vein thrombosis leads to cavernous transformation of the portal vein, characterized by formation of multiple small paraportal collateral vessels. Cavernous transformation of the portal vein. Grayscale transverse image of the porta hepatis shows numerous tubular hypoechoic structures in the expected location of the portal vein, arrows. Color Doppler right image demonstrates flow within these collateral vessels, with no identifiable portal vein. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Portal venous gas. Portal venous gas is due to bowel ischemia, infarction until proven otherwise. If the cause of the portal venous gas is unknown, CT should be performed emergently. Grayscale ultrasound shows peripheral branching echogenic foci that may be transient or seen to change position on cine clips. Spectral Doppler of the portal vein features numerous characteristic spikes. In contrast to portal venous gas, pneumobilia tends to be more central, discussed later in the chapter. Portal venous gas. Grayscale ultrasound through the liver shows numerous tiny echogenic foci, arrows, in a branching pattern throughout the liver, extending to the periphery. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Portal hypertension. Portal hypertension is increased pressure of the portal venous system. Etiology is classified in relation to the hepatic capillary bed as pre-sinusoidal, sinusoidal, or post-sinusoidal. Pre-sinusoidal. Insult is proximal to the hepatic parenchyma, such as portal vein thrombosis. Sinusoidal. Insult is hepatic in origin, such as cirrhosis. Post-sinusoidal. Insult is beyond the liver, such as Budd-Chiari, hepatic vein thrombosis, or IVC thrombosis. Portal pressure is defined as a direct portal venous pressure of greater than 5 mm Hg, although the portal venous pressure is not measured directly. Ultimately, when portal venous pressure is higher than forward pressure, the portal venous flow may decrease below 16 cm, sec or reverse, called hepatofugal. Fugal equals away, same Latin root as fugitive, which is diagnostic for portal hypertension. MPV, CHA, RPV, RA LPV. Reversed equals hepatofugal, number 1F, OW. Hepatic arteries and portal veins, number 1F, OW, in opposite directions. In addition to slow flow or flow reversal, there are several secondary findings of portal hypertension. Dilated portal vein, 13 mm, is the maximal normal diameter in quiet respiration. Splenomegaly. Gamma-Gandhi bodies. Varices. Portosystemic shunts, most commonly gastroesophageal, paraumbilical, or splenorenal. Note that an isolated portosystemic shunt may not be caused by portal hypertension. For instance, isolated obstruction of the splenic vein from pancreatitis-related thrombosis or neoplasm may lead to a shunt. However, a recanalized paraumbilical vein is diagnostic of portal hypertension. Splenomegaly and splenic varices. Sagittal ultrasound in the left upper quadrant shows an enlarged spleen, calipers, measuring 15 cm in craniocaudal dimension. There are numerous tubular hypoechoic structures, arrows, at the splenic hilum representing varices. Transverse Doppler ultrasound of the left lobe of the liver shows a recanalized umbilical vein, which is considered diagnostic of portal hypertension. Transjugular intrahepatic portosystemic shunt, TIPS. Portal hypertension, and reversal of portal flow, can be treated with a transjugular intrahepatic portosystemic shunt, TIPS, which connects a branch of the portal vein to a systemic hepatic vein. Ultrasound is used for surveillance of TIPS patency, starting with a post-procedure baseline. Routine follow-up is performed according to the following schedule: in 1 month, every 3 months for the first year, and then every 6 to 12 months. Flow in a patent tips will be towards the hepatic veins, and flow in the portal veins will be towards the tips. Therefore, flow in the main portal vein will be hepatopetal and flow in the right and left portal veins will be hepatofugal, highlighted below with yellow circles. MPV, RPV, RA LPV, TIPSLHA. Patent tips. Blood number 1F owes through tips to hepatic veins. RPV and LPV have reversed number 1F out toward tips. MPV has hepatopetal, number 1F out toward tips. Patent tips. Color Doppler of the porta hepatis including the proximal tips shows flow within the tips, yellow arrow. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. U.S. can evaluate for stenosis of the tips. Tips stenosis. Spectral Doppler of a tips shows a velocity of 45 cm sec, indicative of stenosis due to slow flow. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. High intra-tips velocity greater than 190 cm sec or low intra-tips velocity of less than 90 cm sec suggests stenosis. Intra-tips velocity change of plus or minus greater than 50 cm sec since the baseline study is also concerning for stenosis. Low main portal vein velocity, less than 30 cm sec, suggests tips stenosis. Transjugular intrahepatic portosystemic shunt, tips, continued. If the tips becomes occluded, the right and left portal vein will reverse and become hepatopetal. MPV, RPV, RA LPV, TIPSLHA. Occluded tips. No blood number 1F out through tips. RPV and LPV have reversed. Now have hepatopetal number 1F out away from tips. MPV has hepatopetal number 1F out towards occluded tips. Tips occlusion. Color Doppler of the porta hepatis including the proximal tips shows complete absence of flow within the tips arrows. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Hepatic vein pathologies. Increased hepatic vein pulsatility. Increased hepatic vein pulsatility is caused by right-sided cardiac abnormality, either right-sided heart failure or tricuspid regurgitation. Both conditions are characterized by accentuated on V waves due to increased retrograde flow during atrial systole. Short. S wave. Accentuated. A wave and V wave. D wave. Right-sided CHF. Preserved. S wave. Accentuated. A wave and V wave. D wave. Tricuspid regurgitation. Anterograde. Into heart. Away from transducer. Retrograde. Towards transducer. Tricuspid regurgitation. Normally, the tricuspid valve closes at the beginning of ventricular systole, the beginning of the S wave, allowing for filling of the right atrium, S wave. In tricuspid regurgitation, there is less or even reversed antegrade flow into the right atrium during ventricular systole, resulting in a prominent A wave and decreased or even retrograde S wave. Right-sided heart failure. Waveform is affected by too much blood volume in the right side of the cardiovascular system, including the right atrium, resulting in tall on V waves due to increased right atrial pressure. However, in contrast to tricuspid regurgitation, the S wave is normal since the tricuspid valve remains competent. Decreased hepatic vein pulsatility. Decreased hepatic vein pulsatility due to hepatic vein narrowing or compression is seen in cirrhosis, Budd-Chiari, hepatic vein thrombosis, and hepatic veno-occlusive disease. Flattened hepatic vein waveform thought to be due to chemotherapy-related liver injury and/or fatty liver. Biliary imaging. Anatomy. CBD. LHD. RHD. Cystic duct. CHD. Normal bile duct anatomy. Sphincter of Oddi. GB equals gallbladder. CHD equals common hepatic duct. CBD equals common bile duct. RHD equals right hepatic duct. LHD equals left hepatic duct. GB. Sagittal view of the normal porta hepatis on CT and ultrasound. Head feet. ANT. POST. Sagittal CT. Sagittal oblique US. Magni, number 1F, ed. Common bile duct. Duodenum. Right hepatic artery. Obscured. Portal vein. Right hepatic artery. Biliary anatomical variance. Low insertion of cystic duct. With a low insertion of the cystic duct, the surgeon may misidentify the common duct as the cystic duct if the patient undergoes cholecystectomy, possibly leading to inadvertent common duct ligation. Aberrant right posterior duct. An aberrant right posterior duct is only important if the patient is a right hepatic lobe liver donor, as the two right hepatic ducts need to be anastomosed separately in the recipient. Long common channel. A long common channel is also known as pancreaticobiliary maljunction, where the union of the CBD and pancreatic duct occurs outside the duodenal wall to form a long common channel greater than 15 mm. It may occur with or without biliary dilatation. This entity may be associated with choledochal cyst, bile duct stricture, and increased risk of biliary cancer. Gallstones in cholecystitis. Cholelithiasis. Single gallstone. Sagittal ultrasound of the gallbladder shows an echogenic gallstone calipers in the gallbladder neck, with posterior acoustic shadowing arrows. Multiple small gallstones. Sagittal ultrasound of the gallbladder in a different patient shows multiple small shadowing gallstones arrows. Cholelithiasis is a gallbladder stone or stones, without associated inflammation. The classic clinical presentation of symptomatic cholelithiasis is colicky right upper quadrant pain after eating a fatty meal, but it is common to see gallstones incidentally in asymptomatic patients. Risk factors for developing gallstones include female sex, obesity, pregnancy, middle age, and diabetes. The ultrasound diagnosis of gallstones is usually straightforward. Stones are echogenic with posterior acoustic shadowing and are usually mobile. It is often helpful to reposition the patient, typically in the left lateral decubitus position, while scanning to assess whether the stones layer dependently to differentiate stones from polyps or other masses. A gallbladder completely full of stones can be more challenging to identify. The wall echo shadow WES sign describes a gallbladder full of multiple stones or one giant stone. Wall echo shadow sign on ultrasound. Two parallel echogenic arcs represent the gallbladder wall and leading edge of the stone yellow arrows, with an intervening thin layer of hypoechoic bile red arrow. The gallstones cast a prominent shadow, obscuring evaluation of the remainder of the gallbladder wall, as in this image. The differential diagnosis of echogenic material within the gallbladder includes gallstones echogenic, mobile, shadowing. Gallbladder sludge echogenic, mobile, non-shadowing. Gallbladder polyp echogenic, non-mobile, non-shadowing, often attached to the gallbladder wall via a stalk, may be vascular. Hyperplastic cholecystosis echogenic, non-mobile, multiple polyps. Porcelain gallbladder echogenic wall, shadowing. Adjacent bowel echogenic wall, dirty shadowing. Acute calculus cholecystitis. Acute calculus cholecystitis is inflammation of the gallbladder due to an obstructing gallstone impacting the gallbladder neck or cystic duct. Patients typically present with right upper quadrant RUQ pain and fever. Acute calculus cholecystitis. Oblique sagittal ultrasound through the gallbladder demonstrates a thickened, echogenic gallbladder wall arrows. The gallbladder contains numerous echogenic gallstones, red arrow. Ultrasound is the first-line evaluation of suspected acute cholecystitis. There is no sonographic finding that is 100% specific for acute cholecystitis. However, gallstones are seen greater than 90% of the time in a positive sonographic Murphy's sign. RUQ pain with pressure from the transducer during inspiration also has a high positive predictive value. Other findings include gallbladder wall thickening greater than 3 mm. Distended gallbladder greater than 4 cm in diameter. Pericholecystic fluid or inflammatory changes in the pericholecystic fat. Color Doppler showing hyperemic gallbladder wall. Axial and coronal T2 MRI shows gallbladder wall edema, yellow arrows, parahepatic and pericholecystic fluid, red arrows, and small T2 hypointense stones within a distended gallbladder. Case courtesy Felipe Boschini Franco MD, Brigham and Women's Hospital. Complications of acute cholecystitis are rare but serious and include emphysematous cholecystitis, gangrenous cholecystitis, gallbladder perforation. Surgical treatment of uncomplicated acute calculus cholecystitis is cholecystectomy. In patients who are not good surgical candidates, a temporizing percutaneous cholecystostomy tube can be placed prior to definitive surgical cholecystectomy. Acalculous cholecystitis. Acalculous cholecystitis is cholecystitis without gallstones, typically seen in very sick patients such as those in the ICU, thought to be due to bile stasis and hypoperfusion. Risk factors include sepsis, prolonged total parenteral nutrition, and trauma. The ultrasound appearance is similar to that of acute cholecystitis, but without the presence of an obstructing stone. Since many patients are ventilated or obtunded, it's often not possible to evaluate for sonographic Murphy's sign. Treatment of acalculous cholecystitis is typically percutaneous cholecystostomy by interventional radiology. Unlike the treatment of calculus cholecystitis, Cholecystostomy is often the definitive therapy. Emphysematous cholecystitis. Emphysematous cholecystitis is a severe complication of acute cholecystitis caused by gas-forming bacteria. It is rare, but elderly diabetic patients are more susceptible. On imaging, gas may be present either within the lumen or the wall of the gallbladder. Treatment of emphysematous cholecystitis is most often emergent cholecystectomy or cholecystostomy in patients with a very high surgical risk. Grayscale ultrasound left image shows diffuse echogenic foci within the gallbladder wall corresponding to intramural foci of gas on axial CT, right image, arrows. Gangrenous cholecystitis. Gangrenous cholecystitis is due to increased intraluminal pressure, leading to gallbladder wall ischemia and necrosis with high risk for gallbladder perforation. On imaging, gallbladder wall thickening may be notably asymmetric and intraluminal membranes may be present. Treatment is emergent cholecystectomy or cholecystostomy. Axial and coronal contrast enhanced CT shows gallbladder wall edema and pericholecystic fluid. There is discontinuous mucosal enhancement of the medial gallbladder wall, red arrow, due to necrosis and perforation with spillage of contents into the right subhepatic space. Gallbladder perforation. Acute gallbladder perforation has a very high mortality due to generalized bile peritonitis. Subacute perforation may lead to a pericholecystic abscess and chronic perforation may cause a cholecystoenteric fistula. Porcelain gallbladder. Axial contrast enhanced CT demonstrates a calcified gallbladder wall consistent with porcelain gallbladder, and multiple peripherally calcified gallstones. Porcelain gallbladder describes a peripherally calcified gallbladder wall, thought to be a sequela of chronic cholecystitis due to either chronic irritation from supersaturated bile or repeated bouts of gallbladder obstruction. Porcelain gallbladder is associated with a, somewhat controversial, increased risk of gallbladder carcinoma. Historically, prophylactic cholecystectomy was the standard of care, however, some advocate for observation in asymptomatic patients. On ultrasound, the gallbladder wall is echogenic and gallstones are almost always present. The differential diagnosis of an echogenic gallbladder wall includes porcelain gallbladder, a gallbladder packed full of stones which will feature the wall echo shadow sign. Emphysematous cholecystitis, intramural gas will have dirty shadowing. Adjacent bowel confused for gallbladder, bowel wall, echogenic gas with dirty shadowing. Different etiologies of an echogenic gallbladder wall in 3 different patients. Top left image shows a porcelain gallbladder with associated posterior acoustic shadowing. Top right image demonstrates the wall echo shadow sign described earlier in the chapter. Bottom left image shows gallstones and dirty shadowing, yellow arrow representing gas in the gallbladder, in this patient following biliary stent placement. Cavasier gallbladder. Sagittal ultrasound of the gallbladder, left image, marked with calipers, demonstrates a massively distended gallbladder. The common bile duct, right image, indicated by calipers, is also distended due to chronic malignant obstruction. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital. The Cavasier gallbladder refers to a markedly dilated gallbladder, originally described as being so large to be directly palpable on physical exam, from malignant obstruction of the common bile duct. A markedly distended gallbladder without acute cholecystitis implies chronic obstruction of either the cystic duct, when seen in isolation, or the common bile duct, when seen in combination with dilation of the common bile duct and intrahepatic biliary dilation. Hyperplastic cholecystosis. Overview of hyperplastic cholecystosis. The hyperplastic cholecystoses are a spectrum of non-neoplastic proliferative disorders caused by deposition of cholesterol-laden macrophages within the wall of the gallbladder. The cholecystoses range from abnormalities of the gallbladder wall, adenomyomatosis and strawberry gallbladder, to gallbladder polyps extending into the lumen. Adenomyomatosis. Ultrasound shows multiple echogenic foci in the gallbladder wall that demonstrate comet tail artifact, yellow arrows. Coronal CT image shows focal wall thickening in the gallbladder fundus with enhancement, red arrow, consistent with adenomyomatosis. Adenomyomatosis is cholesterol deposition in mural Rokitansky-Aschoff sinuses. It is important not to confuse with adenomyosis of the uterus. It may be helpful to remember that there are 3 L's in gallbladder, and adenomyomatosis is a longer word than adenomyosis. Another way to remember is that gallbladder is a longer word than uterus. Adenomyomatosis, continued. Adenomyomatosis is often seen in the gallbladder fundus but can be diffuse or focal. It can be difficult to differentiate focal adenomyomatosis from malignancy. The ultrasound hallmark of adenomyomatosis is the comet tail artifact due to reflections off tiny crystals seen in a focally thickened and echogenic gallbladder wall. The typical MRI appearance of adenomyomatosis is focal, bubbly T2 hyperintense thickening along the gallbladder fundus. Gallbladder polyps. Most gallbladder polyps are benign cholesterol polyps that are part of the hyperplastic cholecystosis spectrum. Rarely, less than 5%, polyps may be premalignant adenoma. Gallbladder polyps are usually incidental and asymptomatic, but may cause right upper quadrant pain or even cholecystitis if they obstruct the cystic duct. The following characteristics, known as the 6 S's, increase the risk for a polyp being malignant. Size greater than 10 mm or rapid growth. As a caveat, ultrasound has limited sensitivity and specificity in detecting small polyps, less than 10 mm, especially in the presence of gallstones. Single. A solitary polyp is more suspicious for malignancy. In contrast, benign cholesterol polyps tend to be multiple. Sessile, broad-based, sessile morphology is suspicious. A polyp is more likely benign if pedunculated. Stones. The presence of stones may induce chronic inflammation, which can predispose towards malignancy. Primary sclerosing cholangitis increases risk of malignancy. 60 age or greater. In patients with several of these high-risk features, cholecystectomy should be considered in the presence of a polyp greater than 10 mm in size. The typical ultrasound appearance of a polyp is a non-mobile, non-shadowing polypoid or sessile lesion extending from the wall into the lumen of the gallbladder. There may be vascular flow in the stalk. Gallbladder polyp. Sagittal and transverse views of the gallbladder show a small non-shadowing echogenic lesion, arrows. After repositioning the patient, this was shown to be non-mobile. The main differential consideration is adherent sludge, which will not have any vascular flow. Gallbladder. Common imaging patterns. Diffuse gallbladder wall thickening greater than 3 mm, common causes in bold. Fluid overload, edematous states. Cirrhosis. Hypoalbuminemia leads to diffuse gallbladder wall thickening. Congestive heart failure. Protein wasting nephropathy. Inflammatory, infectious. Cholecystitis, usually with associated cholelithiasis. Hepatitis. Pancreatitis. Infiltrative neoplastic disease. Gallbladder carcinoma. Metastasis to gallbladder, rare. Postprandial state. Sagittal ultrasound of the gallbladder shows diffuse wall thickening to 8 mm calipers. In this case, the wall thickening was due to cirrhosis and resultant hypoproteinemia. Focal gallbladder wall thickening, common causes in bold. Hyperplastic cholecystosis, adenomyomatosis and cholesterol polyp. Vascular. Varices. Gallbladder varices due to portal hypertension. Sagittal grayscale ultrasound of the gallbladder, left image demonstrates several hypoechoic, cystic appearing structures within the gallbladder wall, arrows. Color Doppler,